Thank you.
A great presentation. And before Professor Ajay Dudani joins in, last presentation, we are running almost 3 minutes behind schedule.
I'll finish fast.
Yeah.
So I think most things have been covered by my esteemed colleagues before me. So I just wanted, my topic was that laser is not dead is what I wanted to say today, As I think Ajay said, micropulse is there, but even the actual laser is there today for us. So this topic was inflammation meets neovascularization in retina. So the thing that came to my mind was Eales disease, where the periphlebitis leads to neovascularization and we treat with steroids, AKT, anti-VEGF and lasers. So I think that's the epitome where both these things are meeting. And also DME, where we have HRFs, which are macrophages with inflammatory IL-6, IL-1, NOS rising, and they respond beautifully to steroids along with lasers. So this, I won't bore you all with this. So diabetic retinopathy, basically there's inflammation. Control of diabetes leads to, the better the control, the less the progression of diabetic retinopathy. We are very aware of that as per the DCCT trial. There's a genetic basis also to DR. I was just now in the free paper session where they said your eye microbiome might be responsible for diabetic retinopathy. I was surprised to hear that you've got a microbiome in your eye also, So high risk PDR is what I'm trying to say, that we have this. You should never forget that in India, patients with high risk PDR, where they're going to bleed with tractional detachment and advanced eye disease, can be prevented only with laser. So most of our patients come with this advanced stage, and the only way we can prevent that is not by multiple injections, but by laser. And I'll just briefly go through this 1 second. So when you have neovascularization, which can be mild or extensive, it can be periphery or on the disc, and it's associated with fibrous proliferation. That's when laser comes up. You don't want the patient to end up with rubeosis iridis. That's the last thing you want. So this is just one, indulge me with this little video because I thought you all will have very dry talk. So here I always, start with disc convert dissection in these patients with PDR, and see, this is how you get at presentation. And post laser and anti-VEGF, if you have a patient like this on surgical table, they'd respond very much better to our surgical maneuvers also. And I just want to say one thing in diabetic retinopathy, you don't want to end up in this stage, because if you do laser adequately in these patients along with anti-VEGF injections, you won't end up at this stage. So the unmet need and the need for anti-VEGF in patients with PDR, there are a lot of studies which have shown that nowadays we are going into basically role of injections only, but pan-retinal photocoagulation shrinks and scars up the damaged blood vessels, and anti-VEGF can be additive in this, and you can have a synergistic effect of anti-VEGF and pan-retinal photocoagulation, which has been proven by various studies. So these are the various protocols which were done by the DRCR. The protocol S, ranibizumab versus PRP, protocol I, ranibizumab with laser versus sham with laser, and the Rise and Right study which was done. So the protocol S, basically I'll just go to the conclusions. They found that either ranibizumab or PRP are as viable. So please don't retire your laser, especially in India where the patients can't afford these multiple injections. Though the patients with ranibizumab monotherapy did a slightly better vision, and the DME obviously resolved. So I think what I do in my patients is I start with anti-VEGF and I add up with the laser, so you don't require those many injections. So it was also proven that anti-VEGFs like ranibizumab reduce the diabetic retinopathy severity score compared to laser, because laser doesn't reverse the disease, whereas anti-VEGFs can actually reverse the disease. The first time we are seeing that the diabetic retinopathy can be reversed. So that was proven by the ranibizumab studies which were done. The protocol I also compared patients with a PDR, and they found that intravitreal ranibizumab appears to be associated with the reduced risk of diabetic retinopathy worsening with or without PDR. So it will prevent the progression from NPDR to severe to high risk PDR patients with injections. And the Rise and Right study had the conclusion that intravitreal ranibizumab reduced the risk of diabetic progression to PDR patients, and the DRSS did improve in these patients. So this is the PRIDE study which we are not very aware of, which assess the efficacy of ranibizumab with or without PRP compared to PRP alone in patients with PDR. So ranibizumab showed stronger effects on neovascular leakage in areas and area reduction while offering better visual results versus PRP. So definitely a combination works, but even a monotherapy can work, and the results of a combination are much better. So in my practical experience, I've seen that when we do laser patients, we used to do PRP to a PDR patient, used to get a rebound macular edema and the patient's vision used to go down. But if the patient has anti-VEGF in his eye, like I give a first injection in a patient with PDR, and then over the next 4 weeks, I'll finish my PRP. And then I give a second injection, so that the macular edema is stabilized, there's no macular edema rebound, and then the second and third injection can take over. But I finish my PDR, especially in the high-risk patients, within the first month of having my anti-VEGF in the eye. So don't forget, I think Dr. Ajay Arora is a very strong proponent of micro-pulse laser, but even the actual laser does work, and I always do focal laser and not grid in my patients with focal diabetic macular edema after I've given injections, and if it's resistant to more than 3 injections, So I think you should use laser judiciously, treat the microaneurysm away from, I now don't go 500 microns, I go more than 2000 microns away from the central fovea, because you have the additional effect of anti-VEGF. This was in the initial studies of the ETDRS when we didn't have these drugs, So we used to go very close to the fovea within 500 microns. And aim for a very light gray burn. Don't aim for those white burns at the macula, because I'm now 30 years into practice, and I've had my patients whom have done, dark burns, which I thought was very far away, that laser scar is increased and, encroached my fovea and I've lost vision. So please try to have mild burns and stay away from the fovea, because over years, these laser scars do enlarge. Grid I do very rarely in my patients, at least patients who can't afford laser and anti-VEGFs, but I have not, I'm doing modified grid that is just like, 1 or 2 rows within the arcades, very well away from the fovea. So again, now this is like, the slit lamp guidelines are very much same, which we are using, 25 years back, and you use the same lenses, or you can use even the LIO. I am more doing LIO delivery nowadays, and all of us are also doing that, unless you have the pattern laser which you are doing. So even pattern laser has, so the advantage is there's much lesser energy delivery here in this, and you can give a multiple number of burns in just 2 sessions in these patients with pattern laser. So this is how the pattern laser looks, and this is how the old laser used to look, and we used to even laser the new vessels directly. So this is the beautiful involution which we get in our patients with PDR. So please, the take home message I want to say is that the synergy of anti-VEGF and lasers is there for us to stay in India. Though I was speaking to one of my colleagues from Jocelyn in Boston, and they have actually retired their laser in USA, in Jocelyn's, but we can't do that because of the cost constraints. Thank you very much for your patient hearing and indulging me. Thank you.
Great, Ajay. You came very late, so actually we lost some of your expertise here. And the take-home message which I got from your thing is that laser is going to stay, but do light laser away from fovea. And if you combine it with injections, the laser intensity is reduced. Thank you very much for such a nice interactive presentation. We'll have a photograph and hand over the mic.